community. So I'm going to share my screen. Hopefully you see my presentation. So today I was tasked to talk about some of the hemodynamics aspect of the disease of CDH. And my disclosure are really relevant to the aspect that there's really just very limited trial evidence in congenital diaphragmatic hernia. And a lot of what we have are based on important research that has been done that remain mostly observational and physiological. And I still think that, you know, when we have very critically ill children in front of our eyes, we need to act with the best evidence. And that's why I think as a community, we strive to give that kind of great and comprehensive care. Otherwise, I don't have any disclosure relative to the content of this presentation. So at the end of this session, my hope is that the participant will be able to explain some of the concepts related to acute pulmonary hypertension phenotype, LV dysfunction phenotype, and as well as recognize some of the shifting cardiovascular phenotypes in the context of the cardiopulmonary interaction, how to address them, and how to implement treatment strategies. I just want to, I'll mention that we do have at the level of Canada a collaborative that has worked together with the Delphi process to outline some of the best practices in order to offer some degree of protocolized care. And that obviously includes a large component of the hemodynamics evaluation and hemodynamics care. And recently, as you all know, there's been the new targeted neonatal echo guidelines that just got published at in the Journal of American Society of Echo, which also integrates a lot of the concepts related to the standardization of hemodynamics assessment in the context of CDH. And so the guidelines are available through the portal of NeoCardio Lab. You can scan the QR code, and I'll put my slides, which contain a lot of the graphs and a lot of the recommendation as well through the portal so that you'll have access to these slides at the end of the presentation. So congenital diaphragmatic hernia remains an orphan disease. It's considered to be 2.6 out of 10,000 total births. And we know that, it manifests with a lot of the abdominal content herniating into the thoracic cavity, creating possibly an element of compression, which alters growth of the organs that we have in the chest and probably also alters the functionality of these organs herniating into the chest, such as a portion of the GI tract. And so what we know from autopsy studies is that the lungs that are being developed into this abnormal state leads to really an abnormal architecture at the level of the parenchyma, probably also at the level of the vessels. And that's really diffused to the entire lung. It's not just like a, one lung that gets compressed and because of that there's problem. It's actually been shown that both lungs are problematic, that there's a component of pulmonary hypoplasia. And more we realize that the chest being impacted at large, there's issue with restrictiveness of the chest, there's issue with scoliosis, but there's also issue of the heart, which is also an organ that is essential to the chest. And so I'll put some of these graphs that are truly wonderful and made by Dr. Satyan, who's been a strong advocate for pushing the research in the field and space of CDH. And so we had recently published this review where I think he cornered that this is a multisystemic disease. And at the bedside, especially when you're coming with your hat of hemodynamic specialist or neonatologist or intensivist, I think it's very important to be aware of, the pathology and pathogenesis, which will affect all of these organs and how there's probably greater interaction between them. And so we know there's a pulmonary parenchymal disease, there's a component of pulmonary hypoplasia, there's less vascular space. We know also there's a remodeling of the vasculature and remodeling of the alveoli, which are structurally abnormal. There's probably some component of airway disease and airway trapping. We know that venous hypertension can be a phenotype that we find in some of these patients who have some degree of left ventricular involvement. And finally, there's a component of probably inherent disease to the heart, where the actual coronary perfusion might be impacted by the shift of axis in the chest, that there might be some component like the acidosis, as well as prenatal factors influencing the cardiac performance. And so when we address strategies to kind of treat these patients at bedside, we have to be aware that these strategies will kind of go hand in hand in really addressing all of these aspects of the care so that you're all very comprehensive, because elements that you're going to be doing on your ventilator, on your support for the breathing or the fluid management, the sedation will impact the cardiovascular system. And we need to be aware of all of these elements. And similarly, as you're going to be addressing the cardiovascular system, you may impact the pulmonary vascular flow as well as the pulmonary vascular drainage. And so we'll try to kind of deconstruct some of these aspects along the talk. Now, I truly believe that the care of CDH starts when you're looking at the hemodynamics from the get-go in the moment of fetal life. So I'm sure that many of you works in centers where you have great collaboration in a multidisciplinary fashion with your surgeons, with your fetal cardiologists, with your maternal fetal medicine. And I think when you're meeting these families and you're planning the care of these patients, it starts from the get-go in fetal life, where I do believe that it's important to understand how the severity of this disease may be able to be predicted on some of the markers that's been described. And so there's been a lot of work being done on pulmonary assessment and very limited data on right CDH. But, up to now, one of the markers that's been the most used is obviously the observed unexpected LHR, and lower levels predicting that there might be more risk for adverse outcomes such as mortality or long hospitalization or requirement for extracorporeal support. And you can see that the values less than 25 in the left CDH or values that are less than 45 in the right CDH tend to confer less survival. And there's been study looking at interventions that could affect this outcome of survival. We know that fetal balloon occlusion or tracheal balloon occlusion could potentially help with the growth of the lungs. We don't have a lot of data on its effect on the heart or the pulmonary vasculature, but we do know that in at least the severe CDH, there seems to be an improved survival, at least from a trial that's been done on a relatively small population, outlining how challenging it is to do some of these trials on orphan disease. And so I think a lot of the fetal space literature informed us a lot on what to expect of these patients in terms of their cardiac growth and cardiac physiology. There's been already studies done outlining that from the moments of 25 weeks, we can already see that some of these fetuses have signs of left heart hypoplasia. So it doesn't seem to be only an effective kind of preload of the left ventricle, but that there might be actually an effective growth of the left ventricle that might be impaired in some of these patients. And some of the possible etiology come from the fetal space where, for example, there seems to be abnormal streaming of blood flow that will preferentially fill the right ventricle, which decreases the growth of DLV. There seems to be potentially an effect of even the small amount of blood flow going through the lungs and filling the left atrium might be also diminished in this population because of the pulmonary hypoplasia. There might be some degree of compression that causes this problem of alveolar hypoplasia. And then finally, more and more, we realize that there might be some degree of programming of mesenchymal migration, which is leading to kind of these sightedness defects where they have issues with their diaphragm, issue with their gut, issue with the lungs, and issue with the heart. And so more and more, there's data outlining how some of these cardiac predictors may be already elements that we can integrate in understanding who are these patients that will have more severe profiles in the postnatal life. Of course, there's obviously other elements like chromosomal anomalies, polyhydramnios, liver herniation. MRI has been a tool that's become the standard of care to predict adverse outcomes. And there's a huge body of literature, and obviously this is outside of the scope of this presentation. But what we know is that there's still a huge chunk of these babies that will have an adverse outcome of mortality. And most of the time, what's been described is death from cardiac dysfunction or pulmonary hypertension or hypoxic arrest failure. And I think that's why, as a community, we're striving to find solution in order to really provide crisp care for these patients as they evolve postnatally under our watch in order to try to move a bit the needle and improve the degree of mortality in some of these patients. I do think that, as I mentioned, you need to provide exceptional cardiovascular care in these patients, and you need to provide excellent respiratory airway care. And all of this needs to kind of be combined together in order to give the best chances to these patients. And that does involve protocolized respiratory management, adequate secretion management, and avoiding excessive oxygen supplementation when it's not necessary. There's going to be a few slides outlining some of the graphs that we constructed for an upcoming review with Dr. Neil Patel, who's been a leader of the field, Dr. Annie Lapointe, and Dr. Florian Kimpfmiller, who've been all very involved in the research of patients with CDH. And I think upon discussion and review of literature, more and more we realize that these patients seems to have like this kind of shifting phenotype, where they start with many of them actually of the most severe profile, starting with a degree of LV dysfunction. And as you improve the LV function, may get this more RV dysfunction phenotype. Other patients will actually present with a pure pulmonary arterial hypertension phenotype and actually seem to respond to some of the therapies that we introduce with pulmonary vasodilators. Although trials have shown that when you don't discriminate these phenotypes with great detail, you could be injurious to some of these patients, and you may actually lead to more pulmonary vascular congestion and possibly to more ECMO in some of these babies. So you have to be very cautious of all of these aspects, and you do have to integrate the gentle ventilation and a patency of the ductus sometimes in order to manage these different phenotypes that we will outline. So if I start from the beginning of the delivery, there are Canadian guidelines and there's a Euro Consortium guideline providing a lot of, basic recommendation for the care in the delivery room. I think many centers, at least in the US, still resuscitate these patients on 100%. Locally, we decided to start resuscitating these patients on 21%. And I know there are studies ongoing to see what's the best strategy for these patients. We do intubate these patients in the delivery room, and we do decompress their stomach in the hope to decrease the effect on the lungs as well as on the pulmonary vasculature to improve preload to the left ventricle. We try to have some degree of permissive hypercapnia in these patients while avoiding profound acidosis. We do aim pre-ductal saturation in the 85%, and sometimes we even accept lower in the first hour of life. And we try to aim what we call a gentle ventilation. And if I can send out a message out there, I think being gentle with these patients, gentle hemodynamics, gentle ventilation, gentle approach. The idea is really to try to have very thoughtful interventions and without creating an opportunity for neglect. I think what's important is to really kind of have a thought process of what you're going to be doing to intervene in these patients and how to be the most physiologically driven while avoiding elements of the care that could be disturbing their homeostasis. So we do tend to use some degree of high frequency ventilation in those patients that have high peak inspiratory pressures, and we do locally use some light analgesia or sedation, such as low dose fentanyl, if we do have signs of some degree of cardiovascular instability. But my message is, if you don't think you need a therapy, you should stop it, or you should not even start it in the first place. So these, little guidelines come from the Canadian guidelines. The summaries are there, and some of the strength of consensus were outlined by the authors. And, everything I've outlined previously are included in this table. In this actual publication, we did provide some degree of targets with the references, which include ventilatory setting and oxygenation. And we know that oxygen is a drug itself acting on the pulmonary vasculature, but on one hand can help the pulmonary vasodilation, on another hand can be quite inflammatory. So we do have to be careful the way we use it. This other publication actually compared the Canadian guidelines to the CDH Euro Consortium, and I think what you can see is that there's a pretty large consensus across the continents about the best, targets for these patients in terms of their urine output, lactate level, as well as saturation and mean arterial pressure to be used for monitoring. Although I think we all know that more and more this does not mean much. So what are the cardiovascular phenotype in CDH? Well, traditionally, it's been well recognized that these patients seem to have a large component of pulmonary arterial phenotype, which means that they have high pulmonary vascular resistances, or at least an increased afterload to the RV that seem to be secondary to a pulmonary vasculature that looks very tight, or that has a low vascular surface area, which is a component that is fixed and that we cannot change much. Now, there's been many publications looking at babies who were extremely severely hypoxic initially and actually recovered after treatment or after ECMO, outlining that there might be some degree of reversibility in some of these babies with this initial phenotype of pulmonary arterial hypertension. Now, in recent years, as I mentioned, there's been more and more an outline that some of these patients has an LV contributor or biventricular contributor, and that actually in the course of action of this patient, there might be shifting phenotypes where once a phenotype is being addressed and the baby seems to be doing better, some stressors like, for example, surgery or pain or hypothermia, which could occur during surgery, may trigger another phenotype like, for example, a pulmonary hypertension crisis. And that's why all the steps along the way for these patients need to be thoughtful, because interventions or side effects of adverse events, such as transitions of care or acidosis or hypothermia, may impact these phenotypes, as well as some of the therapies that we introduce, which may uncover a phenotype that was not obvious in the first place. So there's this beautiful figure which summarizes the idea of these three phenotypes, where some patients are born and have a relatively smooth transition and really don't showcase any much of hypoxic challenges, where they seem to be saturating well, they seem to have a smooth transition and are able to go to surgery without much stressors. And typically these are patients who will not showcase much suprasystemic pulmonary pressure or signs that they have RV or LV diastolic dysfunction. Now, more and more, as I mentioned, we have these patients who seem to have a significant component of right to left shunting at both the atrial and ductal level, where the RV becomes quite exposed to high afterload, which can create compromise to the RV function and eventually compromise to the pulmonary vasculature in terms of providing output, which makes these patients severely hypoxic because you get these pop-offs, if they're still open and still patent, into the systemic circulation, leading to profound hypoxia in the preductal level and eventually even more so in the postductal level, which eventually these patients do present more of a phenotype of acute pulmonary hypertension. Now, we know that some of these patients may have some degree of LV hypoplasia, but also some of these patients may just have some degree of LV dyskinesis and LV dysfunction without having this typical LV hypoplasia. And some patients may have a contributor of both. And knowing that they have some degree of LV hypoplasia, some of them are even tagged as having some degree of hypoplastic arch. And so in these contexts, a lot of these patients will present with high LV and diastolic pressure because there is some LV dysfunction, which increases the left atrial pressure, leading to some degree of pop-off from the left atrium to the right atrium. And typically these patients will present with a relatively okay preductal saturation, because of the effect that they don't get hypoxic blood entering at the atrial level through the atrial shunt, but they will have these pre and post differential saturation, because part of the ductal flow is because there might be some degree of PVR relative to the SVR. But it could also be because there's some degree of compromise to the LV output, which creates this forward flow to actually feed the systemic circulation and perfusion. And so I think that's where it becomes very important to recognize that this phenotype and these phenotype are quite different. And the strategy to address this patient might be different than the strategy to address this one. And so having a component of LV dysfunction or RV dysfunction or even biventricular dysfunction has now been recognized in many studies that were mostly observational, many of which were actually prospective. And you can see that actually up to half of the population may present some degree of LV dysfunction. And some of these patients may have some biventricular dysfunction, and then you need to have a multi-tier approach for some of these babies. And so I think that's kind of what's fascinating about CDH is that you may have some of these patients that have actually an almost hypoplastic left heart physiology, and some of these patients may actually present purely as an acute pulmonary arterial crisis, pulmonary hypertension crisis, which is more of a precapillary phenomenon. And so knowing that there's interactions between the two ventricles, both at the ventricular level, but also at the level of the atrial level, and as well as the shunt physiology, which may be modulated or impact some of the phenotypes, I think it's important to kind of put all of these in the equation when to address the management. And beyond the ventricular interdependence, I think there's cardiac to respiratory interdependence, where you're going to optimize the preload of your lungs and optimize the drainage of your lung, depending on the interventions that you're going to be doing to this patient. So if we look at specifically the aspect of LV dysfunction, we know that LV dysfunction can eventually lead to some degree of pulmonary venous hypertension, as well as some degree of decreased systemic blood flow. And because of that, these patients may start getting poor perfusion to their organs, as well as some degree of pulmonary edema and adverse compliance, which may create issues when you start to intervene with pulmonary vasodilators, for example, where you could worsen the amount of pulmonary edema. In some of these patients, and actually in my practice, I've seen a patient who had a massive pulmonary hemorrhage when started on nitric because it was not well recognized that this patient had actually an underlying component of LV dysfunction. And nowadays that we know that there is these shifting phenotypes, I think we're much more careful in the therapies that we introduce. So many papers have now outlined the contributor of LV dysfunction in cohorts in America, as well as in cohorts in Europe. And so I think that, this graph outlines how there's a component of decreased left ventricular filling, but also sometimes even inherent smaller size of the LV, which may eventually impact the pulmonary circulation and the systemic circulation. And for some of these patients, sometimes the ductus may become your friend, where actually if they start becoming restrictive, you may want to open up the ductus to, first of all, offload the right ventricular pressure, as well as promote forward flow to promote your systemic perfusion. And so this particular table will be in the upcoming review, and it's a beautiful schematic that's been developed by Dr. Patel and Dr. Lapointe, where they actually outline by different phenotypes what would be some of the strategies that we would want to treat these patients, such as providing inotropical support to increase performance of the heart, or actually working on some of the degree of the precapillary component, or having like a combined approach where there's a need for titration, up to the idea that some of these patients may require ECMO, depending on the degree of the severity. So this brings me to assessment by TNE. I've put some slides about the concepts of the echoes because it is an echo talk, and I think it's important to understand these concepts. There's been multiple guidelines promoting various kind of metrics. I think what's important is that in each of your institution, you become familiar with the message that these metrics are providing you at bedside and how you integrate this in your clinical flow, and what might be the most yield and the highest inter-rater reliability among the different practitioners that are doing TNEs and hemodynamics. But I think what's important is that while staying focused, it's important to be comprehensive, to try to get this information about, the right and the left atrial function, the right and the left ventricle, the shunts, and what's happening at the level of the pulmonary vasculature, as well as the systemic vasculature, in order to make educated interventions. And so in this guideline, we actually provided a table with many references. Some of them are for assessment of pulmonary pressures or getting estimate of the relationship of PVR to SVR. Some of them are for cardiac performance, and some of them are for the RV-LV interactions. So I'll try to go quickly over these parameters, although I don't want to have a piece of your soul die in this room. So I'll try to go through this in a seamless way as possible. The first one, which is the most classical one, is the tricuspid regurgitation velocity, which provides you an estimate of RV systolic pressure. Now, a TR is not always available, but it will provide you with an estimate of what's happening at the peak pressure in systole for the right ventricle. And knowing that the RV is connected to the pulmonary artery, pending that there's no other congenital heart defect or no pulmonary stenosis, for example, you could assume that the RV systolic pressure represents what's happening at the PA level. And so we use the Bernoulli equation, and we convert the velocity that we obtain at the peak of systole into a pressure gradient. And so you are able to get an RV to RA gradient, which, if we have an estimate of our RA pressure, can give you an estimate of RV systolic pressure. So in this case, if we have 119 millimeters of mercury at the level of the TR, and you add 5 of estimated RA pressure, which is probably underestimated if you have diastolic dysfunction of the RV, which will increase your RA pressure, you would get about 124 to 130 millimeters of mercury at the peak of systole in your RV. And then you can compare that to what you're seeing in your aorta as getting the relationship between your RV and your LV pressure. So in this case, if a patient has a systolic systemic blood pressure of 65 and the descending aorta, you can say that this patient has twice systemic pressures in the pulmonary compartment. And so we typically will see a blue jet, which is going away from the probe in these patients, which outlines some degree of tricuspid regurgitant. And you want to take the chin and not the hair of the beard in order to quantify your velocity, here being an RV-RA of 97 millimeters of mercury. And here, another example at 51. Second is the ductal flow pattern, which I think can inform you a lot on the relationship between what's happening in the pulmonary artery and the aorta. Now, remember, if you have two structures that are connected, eventually you will equalize pressure between them throughout the cardiac cycle, but you can still get a sense of the relationship between what's happening in the pulmonary compartment relative to the systemic compartment. This is a patient with a relatively large duct that is left to right because it's red, informing you that there's flow coming from the aorta and going to the pulmonary artery. So you would assume that this reflects that the SVR are higher than the PVR. It's not telling you that the PVR are necessarily low. It just tells you the SVR are higher than those in the pulmonary compartment. So we can also use, if you see this PDA, which is bidirectional, it looks like there's higher velocity. So you have the QRS here. This is systole. So it tells you that it's blue or negative or right to left in systole, informing you that in systole, the PA compartment has a higher pressure than what's happening in the systemic compartment. And there's some degree of restrictiveness in the sense that you have pressure up to 30 millimeters of mercury that is higher in the PA compartment compared to the systemic compartment, at least in the systolic component of the cardiac cycle. When the duct is nicely open, there is relatively rapid equalization between the two compartments. And you can see here that this is a bidirectional, but actually that the pressure gradient are almost, they're very minimal. There's only 3 millimeters of mercury between the two compartments. And then finally, you have a situation where you have a completely right to left shunt, which informs you that the PA has a higher pressure than the systemic compartment in the context that this duct looks very restrictive. So you can see here the negative flow, and there's a gradient of 46, informing you that the PA pressure has at least 46 millimeters of mercury above the aortic pressure. Now, you have to remember that we're using the Bernoulli equation and that the duct is a tubular structure and not a narrow point. So we might be underestimating actually the real velocity gradient. Here you have actually a relatively large duct that is right to left. It's completely blue going from the PA to the systemic compartment. And you can see that the velocity are relatively low. So there's rapid pressure equalization, which tells you that the pressure are relatively similar between both compartments because the two structures are connected and this will pressure equalize very quickly. But it tells you that likely your PVR are higher than your SVR. Pulmonary insufficiency can inform you on diastolic pressure because it occurs during the diastolic component of the cardiac cycle. I've put the equation there. I'll let you read on my slide that I'll make available. Septal curve is something that is quite used. And as you know, the interaction between the two ventricle will inform you to some degree about what's happening on the RV versus the LV compartment. And so in systole, when the outflow tracts are open, if there's pressure equalization between the two ventricle, you start to get some flattening. So we call this isosystemic PA pressures. And if you get bowing, you start having suprasystemic RV pressures. And it's either because you have, high RV pressure, low LV pressure, or maybe a component of both, or maybe you're just profoundly systemically hypotensive, and that's why your RV is bowing. But you always have to put these things in perspective of what's happening in your systemic compartment. So I've put a summary of why you would have some degree of higher RV pressure relative to higher LV pressure here. More and more, we use what we call the eccentricity index, which is a way to quantify the deformation of the septum. It's basically the ratio of the diameter parallel to the septum to the perpendicular diameter. And there's some authors also looking at the degree of RV dilatation compared to the LV dilatation in the parasternal short axis view, which is a view from on top where you see the RV and the LV in cross section. And typically your LV and when the PA pressure are infrasystemic should be nice and round at the peak of systole. And as you get increased PA pressure or increased RV afterload, you start seeing a loss of this relationship. I'm not going to, well, the PAT on RVAT is also something that's been advocated by the TNE guideline. It's looking at the shape of the RVOT outflow tract pulse wave Doppler, which informs you on some degree of RV afterload. And there's been a lot of publication looking at the shape of the Doppler being parabolic and very smooth in situation where you have low RV afterload and you start having these mid-systolic notching or very rapid acceleration and slow deceleration in context of high PVR or high RV afterload. And the mid-systolic notching is thought to be secondary to recoil from the pulmonary artery walls. Now, for assessing a function, I think we could do a whole talk on this. I think, we could see when a patient has quite significant biventricular dysfunction, but I think it's very important we actually put measures and quantifiers to some of these metrics. We can use TDI as a way to quantify RV and LV function. There's, either velocities of the movement of the walls as well as what we call the myocardial performance index, which normative value have been described and could outline some degree, especially for the follow-up of cardiac dysfunction. It can be done at the RV level or the LV level for the septum and the lateral wall. You can start looking at some of the inflow velocities, which informs you on the relationship of the diastolic velocities during the early passive filling phase or active filling phase, although this is more used for research in the sense that there's not great cutoffs of what should be considered to be abnormal for clinical relevance in the newborn space. This can be done also at the level of the left ventricle. We can look at the LVO and RVO, which informs you a lot on what's happening in terms of the output. Here it's an example of how we would calculate the LVO based on the TNE guidelines. It's actually from the TNE guidelines. Beautiful images where you can obtain an estimate of the left ventricular output based on the Doppler of the outflow tract of the LV, which is here. And you can do the same at the level of the RV. And then I'll skip the systolic diastolic. And then there's the kind of regular conventional measures of LV performance and RV performance. This is an example of the shortening fraction where we look at the diameter in diastole compared to systole. We can look at the ejection fraction, which quantifies the amount of end diastolic volume compared to end systolic volume, using a biplane method of anterior posterior and septal to lateral wall. For the RV, we typically will use what we call the fractional area change, which is a fraction of areas in diastole and systole. We can do this also in what we call the TED view or the RV inflow-outflow view. So this is tricuspid valve, RV body, and eventually the pulmonary valve. And you can do a fraction of the end diastolic to end systolic area. And you can use the TAPSE, which is a good metric of the longitudinal function of your RV, measuring how this tricuspid valve is moving in systole as a surrogate for the longitudinal function of the right ventricle. And there's been normative value to quantify this function. We spoke about the output of DRV, so that's an example of the output. And then, newcomer or something that's been used a lot for research to try to describe subtle differences in LV and RV function is really using softwares that will track the pixels of your LV, either in the parasternal short axis or in apical views, in order to quantify what we call strain, which is a measure of shortening in systole of some of these segments. And you can apply the same concept to the right ventricle. I'm going to skip these elements because these are more for research. I think it's important to keep in mind that, as I mentioned, some of these patients have LV issues and left-sidedness issues, and there's been more and more the concept that some of these patients may have either hypoplastic arch or coarctation, although we've been fooled in some of these patients where it was tagged as coarctation, and in the end, their arch was sufficient. It's probably because of a low filling of their arch that they get that sense. It's not necessarily because they have a posterior shelf or narrow coarctation at their isthmus. And so it is important to have a good visualization of the arch and make sure that you're not missing actually a coarctation in some of these patients to avoid running into the issue that you have a low systemic output, but it's because you have actual structural disease. So it's important to work with your team of cardiologists to have at least one good fetal structural evaluation or one good postnatal structural evaluation, and then being there at the bedside to do interventions that are guided by neonatal hemodynamics. The atrial level informs you a lot. I think if you have a patient that has a continuous left to right shunt, it informs you that the LA pressure is higher than the right atrial pressure, which tells you that the LA is receiving quite enough preload typically, or that for some reason your RA preload is extremely low. So a baby that, for example, had a significant hemorrhage. But in the CDH space, I think that when you see a left to right shunt and this patient has pre and post ductal saturation differences, I think you should start becoming concerned that there might be some component that the LV has high pressures or high end diastolic pressure, and this is the reason why this LA is actually unloading into the right atrium. So when you see a lot of blood flow coming back from your pulmonary veins and filling your left atrium, it's unlikely that this patient has insufficient pulmonary blood flow. And so it's important to recognize this matter because, I always question myself, well, why would I put INO on a patient that has sufficient, preload of the left atrium and significant pulmonary blood flow going from the pulmonary veins? And could there be other interventions which will target my left ventricle, for example, to help the relaxation and help the filling, such as milrinone if my baby has good blood pressure and adequate urine output? If I have bidirectional PFO, well, this is telling me that, the LA and RA kind of filling pressures are relatively similar, and that's why you get this bidirectional shunt. And if you have a full right to left shunt from a right to left atrium, well, it informs you that the right atrial pressure is higher than your left atrial pressure. And this you could see in situations where you have, for example, RV diastolic dysfunction, high RV pressure, and more of a precapillary phenotype. It could also be seen in total anomalous pulmonary venous return. So it's always something you have to rule out in some of these patients that have a strict right to left shunt. And sometimes it can be seen if you have other malformation like a vein of Galen or a hepatic hemangioma or hepatic AVMs. I'll go on quickly for concept of cardiovascular management in the last 5 minutes, because then we'll have a whole case discussion with the fellows to kind of target the management of patients. I think what's important is to be judicious at the bedside, but really have a comprehensive evaluation. So obviously clinically, the history, the trajectory of the patient, the vital signs, the lactate, the physical exam, the liver edge, the urine output. Sometimes you can add NIRS or not if that's something that your center has kind of customary used for monitoring of end organ oxygenation. I think it's important to have judicious use of fluid. You want to avoid obviously fluid depletion if you have a situation that there's been, for example, a concern for bleeding, but you do want to avoid over flooding them with volume and creating a situation of edema, especially if you have already RV diastolic dysfunction. I think echo is important to guide management in order to have, a more precise way to address the underlying physiology, at least until we get more trial evidence of certain strategies being more advantageous for mortality or important outcomes for patient care that are driven by family patient important outcomes. There's guidelines looking at when the first echo should be done. And currently in the Canadian context, it's been advocated that if you have a good fetal echo and if the patient is stable, you could probably wait at 24 hours of age to avoid disturbing the patient. But obviously, if you have a patient crashing in front of your eyes, you probably want to have a targeted, focused evaluation in that patient. My tips is always to avoid excessive manipulation, avoid being too many people. I think it's important to have the most experienced personnel to care for these newborns and to have a multidisciplinary management. And I think to remember that, presence of parents, environment, silent room, having a calm environment for these patients, avoiding too many pricks of skin barriers and painful events is important, the whole package of the evaluation of these patients. In terms of cardiovascular care, again, it depends on the phenotype. There's many agents we could talk about. I think pulmonary vasodilators are typically going to be the first line if you have more of an RV phenotype. If you start having some compromise of your cardiac function, you want to support your cardiac function. So agents that we tend to prefer here are things like epinephrine or dobutamine to support the cardiac function. The reason that I personally prefer epi is that I'm always a bit worried of dobutamine creating too much tachycardia in some of these patients if they're already tachycardic, but if they're not, it's definitely something to consider. Milrinone is an agent that will theoretically improve the relaxation of your ventricle and could be an interesting agent to consider in some of these patients, but it is renally accumulated, so you'll want to avoid intoxication, and it does create some degree of SVR and PVR relaxation. And so if your patient is already profoundly hypotensive, you have to be very careful about that. And then finally, we have agents like PGE, which could be interesting if you have a restrictive duct, especially if you have context of RV dysfunction or LV dysfunction to maintain output to the system. And more, we know from the literature of precapillary pulmonary hypertension that agents like vasopressin and norepi can be used to favor the systemic to pulmonary ratio. In the guidelines, we also speak about, so I'll skip this one. I've put in my slides these aspects that, you may have RV dysfunction, biventricular dysfunction, or pure LV dysfunction. And based on that, there are strategies that we outline, like pulmonary vasodilators or PGE for the precapillary phenotype. If you have biventricular dysfunction, you need to be careful about vasodilators, but you'll probably want to have inotropes on board as well. And if you have pure LV dysfunction, you probably want to focus on the support to the function. And I've put a table with some of the agents that we commonly use with some of their effect on contractility, SVR, and PVR here. And a reminder of some of the other agents acting on the pulmonary vasculature. So we know that the advantage of PGE is that it does act on the duct, but it also acts to some degree on the pulmonary vascular bed. So it could also trigger some degree of pulmonary vasodilation. The issue with PGE is when you start throwing the whole kitchen sink at these patients and they get significant pulmonary vasodilation, and then suddenly you reverse your shunt and you can actually flood your lung and potentially create coronary steal. So that's why it's very important to be astute at the bedside to follow these patients and really to kind of titrate and remove therapies that are unnecessary as the shift is changing in their phenotype. I do want to mention hydrocortisone. It is something that's been recommended by the guidelines. It comes from studies, mostly from animal studies, seeing that hydrocortisone may help to some of the degree of the CMP pathways. And so as such may help in stabilizing these patients, especially that we think that there might be some component of relative adrenal insufficiency, knowing that sometimes their adrenal perfusion has potentially be compromised due to the shift of the abdominal structures. And, there is high recommendation on the use of focused and targeted echo at the bedside to inform strategies pre and post-operatively, as well as to inform for ECMO decisions or ECMO decannulation. PG is outlined in the guidelines. I think we mentioned it already, as well as the use of pulmonary vasodilators. There's been recently a new publication looking at things such as treprostinil in some of these patients with refractory severe precapillary phenotypes, where they were able to, in some cases, avoid ECMO in some of these patients. So it is definitely something to be considered if your center has experience using these types of medications. Finally, ECMO, we could have a full talk on this. I think ECMO should always be in the back of your mind. VV or VA, it really is depending on the center's approach. I'm very excited to hear what some of our fellows have to say in the discussion, but it's really for those patients that despite all your targeted and gentle management, you were not able to rescue their phenotype or their hypoxic respiratory failure. And so also in the recent year did come out with guidelines in 2021 that were updated specifically for CDH and actually provide some indication of where they would recommend to consider ECMO despite the optimization of the respiratory and hemodynamic management. So my conclusion is that for these babies, less is often better, and judicious use of any cardiovascular strategy should be introduced stepwise and based on the underlying physiology. I do think that the multidisciplinary care is very important and that the team should be kind of fusional around these patients because really the devil is in the details. I think the respiratory as much as the heart are very important. I think no heart can help a lung that is going to be completely broken. And when needing cardiac support, I think that targeting the underlying phenotype is going to be the most judicious strategy, that this phenotype may change and that sometimes time is a treatment, but you need to be aware that with time you introduce therapies which can bring some degree of iatrogenism and eventually could lead to some degree of harm to some of these organs. And so that's why the ECMO question is always like a good question, especially when you start seeing some adverse lung changes in some of these patients on mechanical ventilation. So thank you. This is the QR code for my portal, and I'll be posting those slides. And I think the recording eventually will be available on the NHRC site. So I'm closing this presentation.
Thanks so much, Gabriel. That was exceptional. And so thank you so much for a really fantastic presentation on CDH physiology. I am going to bring up the QR code for everyone to fill in the evaluation.